Thank you very much. I can't hear you, Dr. Sandy. You need to unmute.
Okay.
Okay. Now,
sorry. A 52-year-old woman undergoes radical cystectomy for the treatment of transitional cell carcinoma of the urinary bladder, and neobladder is formed from the segment of the dejubalized ileum. Which of the following is the most likely electrolyte abnormality to occur? Hyperchloremia.
Yeah, excellent. It is a hyperchloremia indeed. Most of the cases of urinary diversion, they don't develop any electrolyte problems. It's not common, but if amongst the commonest is hyperchloremic acidosis, due to loss of bicarbonate, and when bicarbonate is lost, then chloride goes up to maintain electroneutrality. You know this story, this common story, right? Eventually causing hyperchloremia. So, correct, hyperchloremia is the most common abnormality that is seen in urinary diversion in general, especially when you use ileum, detubularized ileum. Okay, nice. Let's look at the next one.
Which of the following muscles will be affected in anterior compartment syndrome of the leg? Tibialis posterior, peroneus longus, peroneus tarsus, flexor hallucis longus, flexor digitoria longus. Peroneus tarsus.
Yes, so anterior compartment, tibial compartment, anterior tibial compartment is the most common compartment involved in compartment syndrome. That's correct. And this compartment contains tibialis anterior and extensor hallucis longus and extensor digitorum longus and peroneus tertius, right? Many people confuse that peroneus tertius is a muscle of the lateral compartment, right? It's not right. There are two muscles only in the lateral compartment, right? Which is peroneus longus and tertius. Now, I have a question. Okay, so what is the site of insertion of peroneus brevis? Where does peroneus brevis insert? Yes, base of fifth metatarsal. That is correct. What is the usual type of fracture that occurs at the base of the fifth metatarsal? And what are the forces that are, what's the mechanism of injury? That was my original question that I wanted to ask. Okay, so you said that peroneus base of fifth metatarsal. No, marsh fracture usually affect the neck of the second metatarsal. Marsh fracture or stress fracture usually affect the neck of the second metatarsal bone, not the base of the fifth metatarsal bone. Is that right? So what's the fracture? You have to tell me this. I'm not going to answer that. The fracture at the base of the fifth metatarsal, what it is? Jones fracture. Yeah, Jones fracture. Okay, so suppose the patient underwent inversion injury. What type of fracture that can occur in the fifth metatarsal and how? If the patient fell on the inverted foot, suppose was chasing a cat and fell on the inverted foot and fractured the base of the fifth metatarsal. How did that happen? So a moment ago we said that peroneus tertius inserts at that location. So if there's inversion, you can imagine. If there's inversion injury, what's going to happen? There's traction. The tendon is stretched and there's traction on the base of the metatarsal. So there's avulsion fracture. Is that right? Would you agree with me? I've seen this question in some exam, but I can't recall what exam it was. But essentially, when there's inversion, then there's traction, then there's avulsion, right? That's the general idea. Now, what other injuries can occur with inversion injury of the foot? So you're in the clinic, patient comes about, patient says, I fell on the inverted foot. And so you're suspecting what kind of things, if you do radiological studies like X-ray or MRI, what are you hoping to find or expecting to find in this particular case? Inversion. Now, please, everyone right now, I'm not going to draw any diagram. I will try to make it clear just by talking. Everyone now, put your foot in inversion. I'm doing it right now, okay? Put your right foot in inversion and stress it on the ground. Stress it while you're inverting it. You will notice two things. Number one, there is stretch on the lateral side and there's compression on the medial side. Isn't that right? There's stress on the lateral side and there's compression on the medial side. The stretch on the lateral side will tear the lateral ligament, mostly anterior talofibular being the commonest. So if there's stretch on the lateral side, medial side, there is compression. So there may be compression fracture of the medial malleolus. Now, I ask you please to evert the foot. Now, I'm doing it too. Evert the foot and press it against the ground. Again, you will notice two things. There's stretch on the medial side now, and there's compression on the lateral side. Is that right? So it means that the medial ligament, which is deltoid ligament, may rupture away, or it may avulse the medial malleolus. Because we know that deltoid ligament is very strong, it may not rupture, rather it may tear a piece of bone, which is the medial malleolus. And there is compression on the lateral side, so there may be compression fracture at the lateral malleolus. Are you understanding me? Or there's a problem with this little experiment? You're understanding me. Good. Okay. Let's move to the next question. Yes.
A 75-year-old man is scheduled for an abdominoperitoneal excision for a rectal carcinoma. As a part of the enhanced recovery program, he was given a carbohydrate-loading drink the night before the operation. How does pre-operative carbohydrate-loading drinks improve the outcome of surgery? A, the utilization of fat resources, it decreases. B, it improves abdominal wall function. C, it improves hydrogen balance and reduces insulin resistance. D, it improves respiratory muscle function. E, it improves sugar levels in the perioperative period. C, it improves nitrogen balance and reduces insulin resistance.
Yeah, so that's correct. improves nitrogen balance by contracting the stress response. Very excellent. Let's move to the next question. Okay.
A 39-year-old woman present with a 2-centimeter breast lump. On examination, the lump looks benign. Mammography is done and the result is reported as indeterminate. What is the next best step? A. Reassurance and distress. B. Order breast MRI. C. Arrange a core biopsy. D. Order a breast ultrasound. E. Lumpectomy. C. Arrange a core biopsy.
Imagine just yesterday, okay, just yesterday, one of the SHOs sent me a message on my cell phone about a woman who presented with breast mass, okay, in our unit. Unfortunately, she was 34, 36, around that. She was not advanced age. Anyway, that mass was very big, so they thought it may be phylloid tumor. Look at the bad management. Just look at that. Made me very, very, very angry. I made a huge fuss about it. But anyway, of course, you have to follow the triple assessment. That is history and examination, and then tissue biopsy, usually core cut. Right before that, there is ultrasound or MRI or mammography according to the clinical scenario that you're facing. Now they went ahead and did lumpectomy immediately on that mass. Okay, they did lumpectomy on that mass immediately. They treated it as if it is fibroadenoma or something, although clinically it was fixed mass. And it was very clear clinically that this is advanced breast cancer. There was beauty orange and there was retracted nipple. It is not phylloid, okay? Anyone, even in the street, you bring someone, a mechanic or anyone, they will tell you this is cancer. So, unfortunately, they did lumpectomy. Pathology report showed invasive ductal carcinoma. It was Bloom-Ricketson grade 8. So it means it is very poorly differentiated tumor. It was triple negative too. Okay, that's not what made me angry. Actually, the management was wrong. Actually, the lumpectomy in that management was very wrong. She should have had that is core cut biopsy. Now, when they did lumpectomy, they've canceled the prospect of doing sentinel lymph node biopsy. Is that right? You can't do it anymore because there's scarring tissue. So it means the axilla needs to be treated aggressively if it is treatable case. So that's one wrong part of the management. But that's not what made me angry. What made me angry is that they discharged this woman to another country without telling the relatives that this is highly BRCA case, right? Highly genetic, because she's young and it's triple negative and it's poorly differentiated. So it's likely genetic case. Is that right? Would you agree with me? So it means the other family members should have been screened. Her daughter should have been screened. Her sister should have been screened. All of that. So in I'm not saying that my unit is bad, but in every unit, there's a disaster that happens once in a while, right? There's a huge disaster that happens. These are called never events, right? Never events means, like, for example, you amputate the left limb instead of the right by mistake. That's never event. The nasogastric tube, you inserted endobronchial instead of nasogastric. That's never event. You forgetting an instrument in the abdomen. That's never event. That's one of the never event-like situations that happens. So going by the book is not bad. Some people say going by the book, or going by the book is the correct way, right? Someone who says don't go by the book is someone who doesn't know what they're doing. So as you said, doctor, it is arrange core biopsy. Okay, let's see the next question.
A 20-year-old female present to the breast clinic with a firm, painless, mobile mass in the upper outer quadrant of the left breast. Ultrasound examination revealed a well-circumscribed solid mobile mass size 2 cm. What is the best course of action?
Okay. So in this case, we all may argue about this case. All of us may argue about this case because breast disease may be managed differently in different countries, right? So if you go to the United States, same case like this, they will take core biopsy, right? That's according to PubMed. They will take core biopsy out of this mass, right? But in the United Kingdom, according to the NICE guidelines, a lot of people don't agree with that practice, but that's what's in the United Kingdom. That cases that are straightforward fibroadenomas, right? So this is a young female. She has painless mobile mass, which is shown to be very benign on ultrasound. That is well circumscribed, and it's 2 centimeter in size, is fitting with fibroadenoma, right? In the United Kingdom only, almost only in the United Kingdom, these cases, according to NICE guidelines, not according to me or anyone else, they can be discharged. Follow-up, even no follow-up. You can find this on NICE guideline. Can you imagine? So, because that's on the premise that majority of fibroadenomas, they either regress spontaneously or they remain the same size. The only thing that you need to do according to NICE guideline is safety netting. Safety netting means telling the patient if it increases in size, telling the patient, etc. All of the warning signs. But other than that, you don't have to do even follow-up. So, I'm not saying that this is the correct, universally agreed upon way, but for the purpose of us passing this exam, we have to follow that for the exam purposes. Do you agree with me?
Yes.
Okay, so you said, people said, you are not wrong. Core biopsy, actually, as I told you, in the PubMed, it's correct management. It's a correct way of management, but that's not in line with NICE guidelines. So just to pass the exam, we will go with option C, which may seem weird for a lot of people. Even for me, when I first read the guideline, it was weird for me, but that's what it is, okay? So let's see the next question.
An elderly man is known to have a solitary spinal tumor on MRI scan. Respiratory compromise is unlikely if the level of the lesion is at the cricoid cartilage, hypo mandible, or the direct cartilage. Mandible. Oh.
So here they're saying it is unlikely that respiratory compromise would occur. Is that right? Unlikely that it will occur. So you should choose the lowest possible, the lowest possible level, right? Like cricoid. Cricoid cartilage is it's at C6, right? Cricoid cartilage is at the level of C6. Phrenic nerve originate from C3, C4, C5, and mainly C4, the main nerve root contributing to phrenic nerve. So this is way below the phrenic nerve. It means that all phrenic nerve roots are spared if there's a lesion at the level of cricoid. So because it's low lesion, it's unlikely to affect respiration. It will affect intercostal muscles, but the diaphragm, the main muscle, will not be affected. As you can see here in the explanation, they're saying essentially what I said, okay? Let's move, yeah.
A 60-year-old man with end-stage cancer is on multiple drugs and he develops peripheral neuropathy. Which of the following drugs is the most likely underlying cause? Cetuximab, oxaliplatin, 5-FU, methotrexate, doxorubicin, oxaliplatin.
Yeah, so a platinum-based chemotherapy like oxaliplatin, cisplatin, those platinum-based compounds, one of the very famous side effects that they have is peripheral neuropathy. That is correct, right? Peripheral neuropathy. How do they work, by the way? What's the mechanism of action of platinum-based compounds? Yeah? Anyone can help me with this? How platinum-based compounds in general work? They are alkylating-like agents. Not exactly alkylating agents, but they're alkylating-like agents. They work just like alkylating agents, like cyclophosphamide. Cyclophosphamide is the prototype or the one that is usually very famous, right? Cyclophosphamide. So the question is, how alkylating agents work? Is that right? So it means, how do they work? I always think about alkylating agents like monkeys. This way you will never forget. They are monkeys, right? So what happens is that, let me show you quickly on the board, just 1 minute. I will show you on the board here. Alkylating agents, as I told you, they are like monkeys. So imagine that this is your DNA. This is your DNA, okay? And that's another strand of DNA. Now, what alkylating agents do, as I told you, they are monkeys. They are jumping here, holding strands. That's a tail, monkey tail, right? That's one monkey, that's another monkey. Maybe there's a monkey here, right? That's a monkey here, right? That's tail. That's tail, okay. Okay, I'm offended by this diagram. That's tail. So what are they doing, these monkeys? They are cross-linking DNA strands. This cross-linking may be within the strand, within this, like this monkey here, or interstrand. That is connecting two different strands. These monkey job actually prevent the DNA from opening up and replicating, right? It prevents the DNA from replicating properly. So simply that's how they do. They work with it in this way. This include platinum-based compounds, which are alkylating-like, but not alkylating agents, and the usual alkylating agents like cyclophosphamide. Okay. Anyway, let's come back to the discussion here. Doxorubicin, by the way, if you want to know, it's very famous for cardiotoxicity, right? Very famous for cardiotoxic effect. Here's this explanation, shows you what are the commonest side effects in every option. For example, cetuximab, which is what? Epidermal growth factor receptor. The common side effect is skin rash, infusion reaction, but not neuropathy. It does not cause neuropathy. Oxaliplatin, which are platinum-based chemotherapy, they are causing peripheral neuropathy. It's a classic side effect, and it's also dose-dependent effect, meaning you increase the dose, the neuropathy increase. You decrease the dose, the neuropathy decrease, right? Means 5-fluorouracil, right? These are some of the commonest side effects like mucositis, myelosuppression, hand-foot syndrome. Also, neuropathy can occur, but it's not common side effect in 5-fluorouracil. Methotrexate, an antimetabolite. Similarly, myelosuppression, hepatotoxic is famous. It's famous for hepatotoxicity. Doxorubicin is famous for cardiotoxicity. Very famous. Let's go to the next.
43-year-old man suffered leg trauma during a fight. Investigation revealed a fracture of the tibia and fibula with widening of the space between them. What is the type of joint between the tibia and fibula? Syndesmosis, plain, ellipsoid, hinge, ball and socket synovial. A syndesmosis.
Yeah, it is syndesmosis. That's correct. If you want to know, joints are broadly classified into, there's fibrous joint. Fibrous joint is a joint that doesn't have a cavity, like fixed joint, right? It's called synarthrosis, right? There's some collagenous connective tissue connects the two bones together. They are further subdivided, these fibrous joints, into that is sutures, gomphosis, and syndesmosis, right? Sutures are sutures. Gomphosis are the ones that fix the teeth. Syndesmosis is the syndesmosis like this one, right? Syndesmosis is actually slightly movable, right? This term is commonly used in MCQs, not MRCS, but generally in MCQs they use this same term, right? When the joint is slightly movable like this, like syndesmosis, it's called amphiarthrosis. By the way, what are the other name for synovial joints? Other name for synovial joints? Hinge is a type. I mean, can you name synovial joint by another name? Not by type, like hinge, ball, and socket. No, I'm not meaning that. Right? These are called diarthrosis. Diarthrosis, right? Diarthrosis is a synovial joint. Diarthrosis is a synovial joint, right? But this guy, amphiarthrosis, is like syndesmosis. Okay, you can, I don't know, if you want, take a screenshot of this if you want to read it, but it will be recorded anyway, right? Hinge, condyloid, saddle, planar, pivot, all these things. By the way, I remembered a question. You know that the joint between C1 and C2, there are two joints. There is a joint called medial atlantoaxial joint, and there is lateral atlantoaxial joint. Now, we know that the C2 has a dens like this, right? It has a dens. This is C2 mass, has dens. And this is just cross-section, okay? And this is C1 in cross-section. So it's actually, if you want to, like this, okay? So this is C1, C2, you know, and above here is the foramen magnum, right? The foramen magnum is over here. You know, there are this joint between the dens of the C2 and the anterior neural arch of C1 is pivot joint. Yes or no? Do you agree with me? The joint between the dens and the anterior arch of C1 is pivot, or what kind of joint is that? Joint between dens. Okay, let me show you another perspective of that. So this is this is C1 from a superior view, guys. Okay, C1 from, sorry, bad drawing, but this is C1. This is the anterior arch. This is the posterior arch. These are the lateral masses. And this is anterior, okay? And this is the dens. The dens articulate here with the anterior, what's that? Anterior arch, is that right? And there's a ligament called transverse ligament, right? Which it prevents posterior dislocation of the dens. Now, this joint is pivot, right? This is usually said to be pivot. Now, that's not my question. My question is that there are ligaments which attach the tip of the dents to the margins of the foramen magnum. What's those ligaments? Yeah, those ligaments are called anyone knows the name of this ligament? The ligament that attaches the tip of the dents to the margins. These are called alar ligaments. Alar ligaments. Okay, what's the function of alar ligaments? That was a question before, right? What is the function, physiological function of alar ligaments? When the head turns side to side, yeah, excellent. It prevents excessive rotation, right? It prevents excessive rotation. It checks excessive rotation of C2. C2 cannot excessively rotate if it's fixed on 2 points by the alar ligaments. Okay, so anyway, this question, the answer is shown, but let's read it anyway. Yeah, Dr. Sandy, can you hear me?
Yes. A 50-year-old woman with long-standing left loin pain and low-grade fever is found to have a staphylococcus in the left kidney, which organism is cultured for a urine sample most likely to yield Acinetobacter, E. coli, Proteus mirabilis, Pseudomonas aeruginosa, Strep aureus.
Okay. Yeah, so Proteus mirabilis, because urease producing, right? Urease producing organism. This creates alkaline urine, where the Staghorn calculus usually is in alkaline urine. Let's look at the next question.
During a posterior approach to the hip, an artery is identified as running between the gluteus medius and minimus. It is a branch of which of the following: inferior gluteal artery, anterior internal iliac artery, posterior internal iliac artery, external iliac artery, femoral artery.
Yeah. It's coming as a branch of that. The artery that is said to be present is superior gluteal artery. This artery is superior gluteal, right?
Yes.
And superior gluteal comes from?
Internal iliac.
Internal iliac. Which branch of internal iliac? Yes. So you said it's posterior. Some people said, are you sure it's posterior? I have a foggy memory. I think it's posterior, but I'm not sure. Can you check for me, please? Because I can't leave the screen. The problem is I can't leave the screen. I think it's posterior iliac, right? Okay, I'll check it on my phone quickly.
Yes, it's posterior division of the internal iliac artery.
Yes. Okay, so it is posterior division. Yeah, so it's posterior division of internal iliac. Correct. Let's look at the next one.
68-year-old male gardener present with an ulcerated brown nodule on the back of his hand. Excisional biopsy showed this is to be malignant melanoma. Which of the following features may indicate a good prognosis? Class level 5, lymphatic space invasion, sky no2, brush thickness of 0.6 millimeter, acceleration of the surface, brush thickness of 0.6 millimeter.
Yes, so it's Breslow thickness. Breslow thickness, this small thickness, 0.6 means good prognosis, right? Clark level 5 is bad. These are Clark levels if you want to know. Clark level 5 means invasion into subcutaneous fat, means very deep invasion. So Clark level is, yes, it's used for malignant melanoma, but it is poor prognostic factor if you say. The nodes are the worst prognostic factor you can think about, right? So the nodes, the state of the lymph nodes is the most important prognostic factor in malignant melanoma, right? Regardless of depth of invasion. Because let me give you a perspective. Do you know why they use Breslow thickness in the first place? What's the importance of Breslow thickness, right? What is so this is a piece of skin, right? And this is supposed subcutaneous tissue. Now, the thing is that Breslow thickness means depth of invasion, right? Now, they found a correlation between depth of invasion and lymph node status. The deeper the tumor goes, the higher the chances the nodes will be involved, right? So, suppose these are nodes. The deeper it goes, the higher chances that the malignant melanoma will give mits to the nodes. Okay, what does it mean if there is mits to the nodes? If there are positive nodes in malignant melanoma, there is almost sure chance of distant metastasis that may not be clinically apparent now, but sometime in the future it will appear. These are micrometastases, right? So it means that the idea of Breslow thickness entirely is built upon the state of nodes, right? The deeper the thickness, then the higher chances are node. So what if nodes are positive? Breslow thickness will not matter that much, right? Because when nodes are positive, nodes are positive. That's it, right? There's no inference on Breslow thickness or heavily you can weigh on it when nodes are positive. So if they ask you in the exam, what is the most important prognostic factor overall in malignant melanoma, it will be node states. That's also mentioned in Bailey, right? The state of the nodes. Even when Breslow thickness is mentioned in the options. Even if it's mentioned in the options, you should go for lymph nodes. If lymph nodes are not in the options, you can pick Breslow thickness. Are we clear on this point? No problem?
Yes.
Okay. So, okay, let's take like a couple of questions and think that's enough for today. Yeah, let's see the next one.
A 38-year-old man falls onto an outstretched hand. Following the accident, he is examined in the emergency department. On palpating his anatomical step-outs, there is a tenderness noted in the base. Where is the most likely injury in this scenario? Rupture of the tendon of plexus pollicis, scaphoid fracture, distal radius fracture, rupture of the plexus carpi, anaris tendon, none of the above. B, scaphoid fracture.
Straightforward question, right? Scaphoid fracture, mostly scaphoid. Let's move to the next one.
Which of the following substances is a vasodilator? Endothelin, bradykinin, serotonin, norepinephrine, none of the above.
Yeah, so bradykinin is a potent vasodilator. Endothelin is a potent vasoconstrictor. Serotonin can work as both depending on the state of the blood vessels, right? So in inflamed tissues, it's vasoconstrictor, but in normal tissues, it acts as a vasodilator. That's why in cases of carcinoid syndrome, right? Carcinoid syndrome, they have flushing, right? That's a sign of carcinoid syndrome. Flushing means there's vasodilatation. It's caused by, some people say it's by serotonin, some people say by other tumor product like histamine or something like that, because it produces multiple other factors. But they think that serotonin itself can be double action. Norepinephrine is definitely vasoconstrictor. So we end up with this option B. Okay, yeah.
Which of the following is a glycopeptide? Metronidazole, vancomycin, imycin, C. Guanfenicol, tobramycin, B. Vancomycin.
Vancomycin and teicoplanin are both glycopeptides, right? Vancomycin and teicoplanin, and vanco, both of them belong to the same family, which is glycopeptides. That's correct. Let's keep going.
A 39-year-old man is found unconscious at home. His left thigh and leg are swollen and tense, and his urine is dark in color. Which of the following is the best course of action? Restriction of fluids, alkaline diuresis, acidic diuresis, neutral diuresis, Ringer's lactate.
Okay, so what's your opinion, Dr. Sandy?
I'm not sure about this question.
It's okay, no problem. So in this patient, there's traumatic rhabdomyolysis. Would you agree with me on this? Do you agree with me, Dr. Sandy, that this patient have rhabdomyolysis?
Yes.
Yes. So means there's release myoglobin and release of uric acid.
Yes.
So there's likelihood of kidney injury, right? Okay. So one of the ways, the most important way, okay, the most important way in reducing deposition of myoglobin in the kidney. So here's the myoglobin coming in. Also, uric acid participate in the damage. The most important thing is to give fluids. The most important part of the management is to give fluids. The fluid need to induce brisk diuresis. That is heavy diuresis, usually 1 to 3 milliliters per kg per hour and up to 300 milliliters per hour. That's, you can get up to this level of brisk diuresis to reduce the precipitation of myoglobin and uric acid in the kidney and damage it, right? Now, they found that myoglobin does precipitate in kidney tubular cells if the pH is alkaline, right? If the urine is alkaline, it reduces the chances that this myoglobin will deposit in the cells of the kidney. Okay, so now they also found when you give a lot of fluid to the patient, the urine automatically alkalinizes. You don't need an alkalinizing agent. Okay, so when you are giving this patient lots of fluid, the act of giving too much fluid will wash out the acid in the tubular fluid and will will increase the pH urine, right? So it will alkalinize the urine. Some people go a further step to add sodium bicarbonate. Generally, sodium bicarbonate would be advised if there is severe acidosis. That is, pH is less than 7.20, meaning severe acidosis. Not all add it. Not everyone uses sodium bicarbonate, but it's mentioned. Of course, one value is to alkalinize the urine. There's no fun in telling that, right? But also it helps with hyperkalemia. Is that right? Do you agree that giving sodium bicarbonate will help with hyperkalemia in rhabdomyolysis?
Yes.
Yes, it will help because if you remember, when you alkalinize the blood, potassium shifts inside the cell, right? Potassium shifts inside the cell, so it helps with hyperkalemia. So that's another benefit, you can say, from sodium bicarb. Now, option E, what do you think about that? Is that a good idea? Option E, Ringer's lactate. That's a good idea or bad idea?
Bad idea.
Bad idea. Why bad idea? That's correct, it's bad.
Ringer's lactate also contains the potassium.
Contains potassium, right? It will worsen hyperkalemia. This patient already may develop hyperkalemia. That's excellent. So, in the end, this question will be answered as option B. That is, alkaline diuresis will be optimal. As I told you, you don't have to add alkalinizing agent. Just giving fluid will alkalinize it most of the time. Let's see. Let's push in a few more questions.
Myasthenia gravis is associated strongly with which of the following? Small cell lung carcinoma, thymoma, phalange gland polyps, renal cell carcinoma, esophageal webs.
Okay, so what's your opinion, Dr. Sandy?
I just remember the answer, not know exactly know about the condition. The answer was thymoma.
Yes, so it's thymoma. Thymoma is associated, yes, with myasthenia gravis. Sometimes, not always, but sometimes when you do thymectomy, it can improve, even when there is no thymoma in the thymus. Yes, Dr. said small cell lung cancer is associated with Lambert-Eaton. That's in fact very correct. Small cell lung cancer is similar to myasthenia. It's different in a lot of aspects. We've discussed that in previous session, I remember. It's different clinically and pathophysiologically and everything, but essentially very similar. Now, I just want to also highlight another note that small cell cancer is not only associated with this neurological syndrome, it is also with other paraneoplastic neurological syndromes, especially paraneoplastic cerebellar degeneration, right? Paraneoplastic cerebellar degeneration is strongly associated with this type of cancer, small cell lung carcinoma, right? Aggressive type of tumor. We know that.
Hi,
okay,
Doctor. Can I just ask you a question to clear up on that previous one? So can you just say again what you don't give Hartmann's and why is that reason? I didn't quite understand it.
Yeah, no problem.
This one.
So in this, no problem. So this man has rhabdomyolysis, this breakdown of muscle cells. When muscle cells break down, they will release products like potassium. One of the products is potassium, which is, of course, potassium is about, I don't remember the number, but 200 times more inside the cell compared to out. It means cells are just bags of potassium. You can think of them like that. So when they burst, they will release that. Ringer lactate has minimal amount of potassium, but in the patient that is already at hyperkalemia, this minimal amount can be significant, right?
Okay.
So Ringer lactate already contains potassium. Now, it applies to all other potassium-containing solutions or potassium-containing drugs. Anything that contains potassium, like TPN, like some drugs may contain potassium in their chemical situation, anything that contains potassium needs to be withheld, including Ringer lactate. Okay.
And the alkaline diuresis, how is that done? What is given for the correct answer B? What is given for alkaline diuresis?
Yeah, so as I told you that just giving a lot of fluid, just giving so much fluid to induce diuresis, very pressed, like 300 ml per hour, that on its own can alkalinize the urine by washing the acid.
That's why I was confused, because I thought it had to be an alkaline substance, but just normal fluids can do it. I got it. Yeah, thanks.
It can do it, but yes, you're correct. Some people can go a further step and add an alkalinizing agent. That's also true, what you said, that adding sodium bicarbonate is one of the lines of treatment, but it's not commonly performed until there's severe acidosis, like less than 7.20. Okay?
Yeah. Okay, thank you.
Always welcome, Dr. O. Okay, let's see the next one.
Following head tremor, a 20-year-old man complains of anosmia. Which of the following bones is most likely fracture? Cribbon plate or elmoid bone, crystallia, laser bone, maxillary bone, occipital bone? A cribbon plate or elmoid bone.
Yeah, there's no fun in telling that. Ophthalmic nerve fibers traverse that bone. If it breaks, you know what happens. Okay, the next question, yeah.
Which branch of the facial nerve is involved in smiling? Buccal nerve, maxillomandibular nerve, zygomatic nerve, cervical nerve, mandibular nerve. Buccal nerve.
Buccal nerve, yes. So, do you know Amber Heard? Do you know Amber Heard? You know? The actress. You know her, right? Everyone knows her. So in case you don't know her, she was abusing her husband and everything, right? Which is it's kind of very sad story, but she had that smile on her face. But it's not quite a smile, but a smirk, not a smile. It's kind of, smirking, a smirk.
Yes.
You know that, evil stuff. Now, smirking and smiling is different. Amber Heard has lesion in her buccal nerve. She can't, I'm joking, of course she doesn't have that, I think. But just to remind you that smiling is different from smirking, okay? Amber Heard smirks. Smirking is the action of a muscle called rhizorius. Rhizorius. A different muscle. Smiling means that the angle of the mouth is generally, when you think about smiling, is brought up. That action is by a muscle called zygomaticus major. So smiling, zygomaticus major muscle. Okay? Now, the zygomaticus major muscle often have double nerve supply. It has a supply from buccal nerve and has a supply from the zygomatic nerve, zygomatic branch of facial nerve. That's why a lot of people confuse it and answer zygomatic nerve. Other people answer buccal nerve. And they keep arguing about the same question. Of course, it's not marginal mandibular nerve. I see a lot of people answering marginal mandibular. It is not, okay? Now, marginal mandibular nerve, I will just tell you a few things about it that is relevant to this question. The main nerve supply to the zygomaticus major is buccal nerve. It is buccal nerve. According to most books, they say this is the answer, okay? That is buccal nerve. So we will answer this way. Now, marginal mandibular nerve supplies the inferior oral group, which can include mentalis, depressor anguli oris, right? These muscles, they generally depress the angle of the mouth. Is that right? So it's kind of a sad expression rather than smiling. It actually mediates the opposite. But the thing is that when marginal mandibular nerve is injured, suppose in submandibular style adenectomy, for example, commonly injured this nerve in that operation. Now, when this is injured, it will cause a symmetric smile. When the patient smiles because of muscular imbalance of the mouth, the smile appears asymmetric. You get the idea? Do you understand that small difference that comes in the questions and confuse everyone? The marginal mandibular nerve itself does not cause any smile, but when it is injured, it is going to cause an asymmetric smile, but it doesn't mean it's mediating smiling, right? That's the point that I wanted to make. So it's option A. Let's see the last question for this session. That's enough for today. Let's see this one.
A 39-year-old mother presented to the clinic complaining of fever and fatigue. On examination, the right breast is erythematous with a palpable tender lamp measuring around 4 into 4 centimeters is felt in the right breast. What is the most likely diagnosis? Latational mastitis, breast abscess, inflammatory carcinoma, DEC ectasia, periductal mastitis.
Okay. So
the most common is latational mastitis, but if she has the fever, maybe breast abscess, option B.
yeah, so she has a fever. That's one thing. The fever can occur even in lactational mastitis. Lactational mastitis generally. Yeah, so you're correct that she has erythematous. There's palpable lump, right? It is 4x4. So there's definitely a collection. But why not inflammatory cell cancer in this case? I want a very good reason for that. In the case, inflammatory cell cancer present at the same time as that age, generally younger women. They present with fever, tender breasts, everything. Similar, very
Discharge
similar.
plus the discharge.
Come again, Dr. Sandy, please.
Discharge, any discharge plus the discharge.
I couldn't hear you. There's a problem with the voice. Dr. Hanan said localized lesion. Yes, Dr. Hanan, that's correct. Look, inflammatory cell cancer usually almost always does not make a mass. It doesn't make a mass. The tumor melts into the breast literally. The tumor cells, they spread in the breast without creating a localized mass. Okay? So inflammatory cell cancer, it's different in several ways. Number one, suppose let's differentiate clinically. Okay? That's a breast, okay? And look, the inflammatory, the mastitis, the lactational mastitis, usually the redness takes sector of the breasts. Usually, okay, it is not diffuse. It respects a particular sector. Why? Because the infection occurs along a milk duct. So infection will spread along that milk duct and into that part of the breast, and that's what's causing the sectoral erythema. So here, pattern erythema is sectoral. Okay, in the inflammatory cell cancer, let's use this color. That's another breast, women with inflammatory cell cancer. The pattern of erythema is irregular and diffuse. It doesn't respect a sector. That's one difference. So again, in lactational, problem sectoral. In inflammatory, problem diffuse. That's one difference. The other difference is the color. Now, in your usual lactational mastitis, it is bright red, often described as rosy red, like rose, rosy red. Bright red, لون فاقع يعني. It is very bright. So that's one thing. In the bad situation, which is inflammatory cancer, it is dusky red, dusky, more dark, dusky red. So again, this is sectoral, rosy red, dusky red. Another difference is lump. Now, in lactational mastitis, initially there is no lump, there is cellulitis. But if there is abscess formation and localization, the woman will present with a lump in the affected sector. So in case of inflammatory cell cancer, lumps can be there, but rare. So we will say here, usually no lump. But here, when abscess form, there will be lump, right? When abscess form, there's gonna be a lump. Another difference, PUD orange. PUD orange is seen here. PUD orange, that is, PUD orange, the skin manifestation, is seen here in the inflammatory situation, inflammatory cell cancer. Now look, in case of, what's that? Lactational mastitis. In lactational mastitis, as long as there is no chronic abscess, there is no PUD orange usually. Now, I want to also add a small note here. The most, you can say, the mimicker of breast cancer is chronic breast abscess. Chronic breast abscess present with hard mass because sometimes there's calcification and dense fibrosis. It may be fixed because of fibrosis. The nipple can become retracted because of fibrotic reaction around the abscess cavity, and there may be PUD orange even. So you can guess how much chronic breast abscess simulate carcinoma in almost every single clinical aspect. So, with that being said, in lactational mastitis, as long as there is either cellulitis or there is either acute abscess, there will be no PUD orange. But if the chronic abscess form, there will be PUD orange. Is that right? So, doctors asked, keyword is lump? Yes. the only key word provided in this case is the lump. Lump does not usually form in inflammatory cell cancer. Now, I have a question. If you take biopsy from this woman, inflammatory cell cancer, you take biopsy and stain it with immunohistochemistry, what do you think the most likely result will be present with immunohistochemistry? Would you think it will be BR-ER positive, HER2 positive, or negative, or triple negative? What do you think? Is it triple negative? It's triple negative, yes. It's a triple negative, poorly differentiated tumor. It's usually triple negative, unfortunately. I want to also add a small note. You know that staging of breast cancer, T stage, if it's less than 2 centimeters, that's stage T1. If it's 2 to 5, that's stage T2. If it's more than 5, that's T3. If it's fixed to skin or pectoral muscle, that's T4, regardless of size. Is that right? T1, less than 2. T2, 2 to 5. T3, more than 5. T4, fixed to something. Now, if a woman presents with inflammatory breast cancer, regardless, she will be T4. Immediately put into T4. No matter how small it is or early it is, or you get the idea. So it is that bad. So once histology shows inflammatory cell cancer, jump this poor woman, she will be placed into T4. Okay, unfortunately. So that's why all of these reasons that we're talking about right now eventually pours down, is that question is answered as breast abscess. Okay. So that's the end of our session. I hope you've enjoyed that. Do you have any questions for me? Any questions for me, guys? Any questions at all? Okay, I have a question. I have a question for you. What is HER2 new receptors? What is that? Anyone unmute the mic and discuss with me a little bit about that? Dr. said about phrenic nerve root. Okay, let's take your question first, and then I will ask my question. So, what's your question, doctor? It's C4. Trust me on this. It's C4. Just trust me. The main nerve root is C4. That's according to Gray's Anatomy. Okay, so my question now. My question is, what is HER2?
Yes, it's abbreviation for human epidermal growth factor. And whenever it's positive, it reflects a poor prognostic factor for CA breast.
Yeah, so it is excellent. Yeah, it is human epidermal growth factor receptor 2. That's correct. Okay, so how is this receptor activated? And when it's activated, what does it do?
Actually, I don't have more details about the mechanism of action.
No problem. So HER2 is basically a proto-oncogen. You can classify it as a proto-oncogen. Look, proto-oncogens are all those proteins or their products that eventually lead to cell division or proliferation. This includes growth factors, reporter molecules, transcription factors, right? all of those things are proto-oncogenes. So HER2 is actually a proto-oncogen. So it's an oncoprotein. HER2 have no ligand. There's nothing that is known to science that attaches to HER2. But how is it activated then? Let me show you. Actually, what happens is that, let me tell you, that's one HER2 receptor. Okay, that's one HER2 receptor. HER2 receptor itself doesn't have any ligand that attaches to it. But what happens really is that there is another receptor of the same family that have ligand, right? This other receptor which have ligand, it will attach to the HER2 receptor and activate it. This is called dimerization. This is called what? Dimerization. Now, dimerization can occur between HER2 and another receptor of the same family, and this is called heterodimerization. Hetero means of different family. A different type, but same family. Heterodimerization. In breast cancers which overexpress HER2, there's a lot of HER2 receptors already expressed on the surface of the cell. There are so many of them that spontaneously there is dimerization between two different HER2 receptors. This phenomenon is called homodimerization. Homodimerization. When there is homodimerization or heterodimerization, what will happen? There is this is actually going to go to a reporter molecule, which will increase cell proliferation. So cell proliferation increases. And the mobility of the cell and its metastatic potential also increases. Now, what is the drug that we use here in patients that have HER2 positive tumors? What is the name of the drug? It's a common question in the exam. If a woman with HER2 positive breast cancer, of course, it implies poor prognosis, but there's a drug that we give which can improve that. Yes, trastuzumab, or otherwise called Herceptin. So how does it work, Herceptin or trastuzumab? They are monoclonal antibodies that attach to what? What do? They will attach here, these monoclonal antibodies, to the, what's that? HER2. They will attach to the HER2 and prevent dimerization. So the main mechanism of action is that it actually prevents what? Dimerization. That's one mechanism. One mechanism is prevention of dimerization, homo or heterodimerization, so the cell doesn't proliferate. The next mechanism is that this receptor can also bind this friend. What is that friend with big nucleus and a rim of cytoplasm? Cytotoxic T lymphocytes. It can bind cytotoxic, what's that? T lymphocytes. And when cytotoxic T lymphocytes bind to the malignant cell, it can cause cell-mediated cytotoxicity. It can cause the cell to undergo apoptosis. So there are two primary mechanisms by which Herceptin works. Number one, prevention of dimerization. Number two, cytotoxic T lymphocyte-mediated immune response. Okay, so that's it. That's the thing that I wanted to clarify at the end of the session. So, do you have any questions for me before I go? Any questions, guys? Feel free. Okay, that's it. No questions? Okay. Thank you very much, everyone. I really wish you the best of luck. study hard, study well, study the proper way. The most important thing is to study the proper way, not the. If anyone can tell you that you can come, read few pages and pass, that's not realistic. You have to study the proper way. You have to really understand things. Otherwise, there's very high chances that you may not clear this exam well. And even if you clear it, even in the OSCE you will get stuck, because in the OSCE you're facing the examiner. You're facing face to face. You cannot escape, right? So study hard. And if you need me at any time, as always, I always say this in the end of the sessions, reach out at any time. Best of luck, everyone. See you in the next sessions. And until then, I will upload the next mock. So we uploaded how many mocks? So far, I think I've uploaded 3 mocks, right? So tomorrow, inshallah, I will upload the 4th one on the group. So best of luck, everyone. See you next time, inshallah. Good night.